My name is Jody Alwyn. I'm the Medical Education Director for Cardiology. I would like to now introduce our moderator, Dr. Bill Abraham from The Ohio State University. Dr. Bill Abraham was the PI for both feasibility and pilot studies and developed one of the first combined heart failure and sleep apnea programs in the United States. So, Dr. Abraham, would you like to take it away?
I would. Thanks very much. And I too would like to welcome everyone to today's webinar on sleep medicine and cardiology partnerships, improving patient outcomes in the telemedicine era. I hope that you will find this webinar to be quite timely and relevant to your practices. It addresses a very important topic, and that is of sleep disordered breathing or sleep apnea in cardiovascular disease patients, particularly those with. And so let's go to the next slide, Jody. Here are my financial disclosures, and Jody's already mentioned that I've worked with Respicardia, the sponsor of this webinar. So next slide. Let me briefly take you through the agenda over the course of the next hour. We'll briefly discuss sleep medicine and cardiology collaboration. Then we'll hear from Alan Schwartz about home sleep testing during the COVID-19 landscape. Then a discussion on obstructive sleep apnea and treatment options for heart failure patients by Neomi, Shah. And finally, Lee Goldberg will finish up with a focus on central sleep apnea and treatment options. Next slide. Our objectives for this webinar are to develop effective collaboration between sleep medicine and cardiology, to implement strategies for identifying and testing heart failure patients with sleep disorders during the COVID challenge and beyond, to identify the right therapy for the right heart failure patients with obstructive sleep apnea, and to discuss new data and treatment options for central sleep apnea in heart failure. Next slide. And finally, by way of introduction, I would like to introduce to you our distinguished panel of speakers. We're really very lucky to have Alan Schwartz, Neomi, Shah, and Lee Goldberg join us today as they represent experts and thought leaders within the field of sleep medicine and cardiovascular disease. Alan Schwartz is a professor of medicine, now retired at Johns Hopkins, and I think also an adjunct, Alan, at the University of Pennsylvania. He directed the Johns Hopkins Sleep Disorders Center and launched and directed the Sleep Medicine Fellowship Training Program and the Center for Interdisciplinary Sleep Research and Education for many years. He has extensive experience in conducting clinical trials of diagnostics and therapeutics for sleep and breathing disorders. Neomi Shah is an associate professor at Mount Sinai. She's board certified in internal medicine, pulmonary critical care, and sleep medicine, and has been focused on understanding the complex relationship between obstructive sleep apnea and cardiovascular disease. And finally, Lee Goldberg is a professor of medicine at the University of Pennsylvania, where he is chief of the Advanced Heart Failure and Transplant section in the Division of Cardiovascular Medicine, and has been very engaged with the remedē development program, including being a member of the steering committee for the remedē pivotal trial and PI for the REST study, which is ongoing. Next slide.
Next step now is fixation of the...
So I'll kick things off with a very brief discussion on sleep medicine and cardiology collaboration. I think this is critically important. I recognize a number of the attendees listed on the webinar, and I know some of you have already accomplished sleep-heart collaborations at your institutions. Maybe others haven't, and I hope that after this discussion, you'll all go back to your institutions and work on building these relationships in order to advance the field of sleep medicine and cardiovascular disease. So let's go to the next slide, and let me briefly describe, why this collaboration is important. It's important because sleep disordered breathing is largely a cardiovascular disease. While obstructive sleep apnea affects patients both with and without cardiovascular disorders, it's more highly prevalent in those with cardiovascular disease. And as I'll show you in a moment, central sleep apnea in particular is a disorder that is found predominantly in cardiovascular disease patients. So if one looks at the prevalence of sleep disordered breathing in cardiovascular disease patients, you can see that it affects nearly a third of patients generally described as having cardiac disease, about 30% to 60% of atrial fibrillation patients with normal LV function, 60% of stroke survivors, about 75% of heart failure patients, and more than 80% of drug-resistant hypertensive patients. So this really highlights why this partnership is so important. And let's go to the next slide where we'll focus on central sleep apnea. You can see that central sleep apnea really and most truly is a cardiovascular disorder being seen predominantly in those who have cardiovascular disease. Now, there are idiopathic forms of central sleep apnea, and there are other disorders and drugs such as opioids, which may cause central sleep apnea. But when you look at who the CSA patients are, about 75 to 80% of them have heart failure and or atrial fibrillation. Another 10 to 15% have brain injury, either due to chronic neurological diseases or to stroke. And about 5 to 15% are idiopathic. And 50% of these patients, at least those who have been included in clinical trials of CSA, are 65 years or older. But that also means that there are plenty of younger patients who have central sleep apnea. And why is it important to treat CSA? Well, you're going to hear a lot more about this from Lee Goldberg in a few moments. But we know that patients with central sleep apnea are 50% more likely to have a heart failure-related readmission. They have twice the mortality rate in heart failure patients. It increases the risk of other comorbid conditions and causes hypoxia, fatigue, and poor quality of life in patients. So to further emphasize the need for collaboration, this is a study that Shahrukh Javahari and I did a few years ago. It's published nearly a decade ago, although I'm not sure that we've made much more progress since this time. But really the main point of this slide, which evaluated the Medicare standard analytical files to determine at that time how good of a job we were doing in screening heart failure patients for sleep disordered breathing. The bottom line, without taking you through all the numbers shown on this slide, is that only about 2 to 4% of heart failure patients were undergoing screening for sleep disordered breathing, and or received any form of treatment for sleep apnea at the time. So this really underscores the need for engagement of both sleep medicine specialists and cardiologists in tackling this enormous problem of sleep apnea in cardiovascular disease. Next slide. So an approach that we developed at The Ohio State University a number of years ago, and certainly this type of integrated collaborative program has been established elsewhere as well, was to develop a strong partnership between cardiovascular medicine and sleep medicine, leveraging our dedicated heart hospital and our sleep medicine center to create a fully integrated clinical research and teaching program, which combined sleep medicine and heart failure clinics and actually brought them into our subspecialty heart hospital, brought sleep medicine into the heart hospital so that we could establish a program of aggressively screening our cardiovascular disease patients for sleep disordered breathing. We developed the ability to evaluate both inpatients and outpatients with both screening and comprehensive testing, and you're going to hear a lot about testing for sleep apnea from Alan Schwartz in a moment. But the bottom line was that this enabled us to focus on groups of cardiovascular disease patients, such as patients with heart failure, with atrial fibrillation and other arrhythmias, and patients with ischemic heart disease going to the operating room for revascularization, and have a focused, systematic approach to screening and treatment of those patients. Next slide. Just tells you a little bit about the multidisciplinary team that supports this sleep heart program. This sleep heart program has brought together heart failure providers, including physicians and nurse practitioners, sleep medicine specialists, physicians, along with the sleep clinic, electrophysiologists and the EP lab, device experts and clinical nurses and MAs to enable this systematic approach to screening and treatment of the cardiovascular disease patient with sleep disordered breathing. So with that, I'll conclude my presentation on sleep medicine and cardiology collaboration, and we'll move on to Alan's discussion of diagnosing and treating sleep apnea. Alan?
Thank you very much, Bill, and let me know if you cannot hear me. Really appreciate the opportunity and the chance to interact with all of you. I'm a little sheepish because Bill alluded to a number of really prominent programs in which these collaborations between sleep and cardiology have been well established. To some extent at Hopkins, Bill has highlighted the program at Ohio State, and I know that there's published data now from University of Pennsylvania, and folks at University of Chicago have been working on this as well. The tagline here really is the more convenient we can make sleep testing to the cardiology community with point of care testing, the more effectively I think we will be able to drive these initiatives for the betterment of patients. And so building these relationships, these alliances, does involve collaboration amongst different medical disciplines, but also involves deployment, judicious deployment of home sleep testing technology, whether that technology is being deployed in the home or in the inpatient services or at point of care in the clinic. And so I'd like to, by way of disclosure, and I'm not sure I have control.
You should have control. Yeah, there you go.
Yep, okay. I have a number of different disclosures for largely for small startups and small companies in the sleep diagnostics and therapeutics arena, as well as some NIH-sponsored work in this area. I'd like to, just over the next few minutes, really touch on some broad issues that should govern our decisions about how to deploy home testing. And I would say that there is not one distinct method to recommend, but really to recommend methods that are that play into the strengths of the particular practitioners involved. And in so doing, what I'd like to do is really highlight the issue of sleep, and sleep apnea in particular, as a source of cardiovascular stress. Secondly, I'd like to really touch and give you just a brief overview to frame our discussion of home sleep testing or portable sleep testing platforms. That's the technology I'm speaking of. And really just briefly touch on operational issues that govern your decision as to which testing platforms and how to deploy those tests in various settings outside of bricks and mortar sleep labs. And invariably, when we're talking about home testing platforms for doing diagnostics in the sleep disorder breathing space, what we're talking about really is curbing some of the physiologic disclosure that we get with all the channels for in-lab polysomnography, all the physiologic signals, and really focusing on some subset which we think are going to be particularly informative in helping to establish a diagnosis of both the presence of sleep disorder breathing and the type and severity of the sleep disorder breathing patterns. And so what I would say is let's do that by really with a keen eye toward looking at sleep as a source of cardiovascular stress. And many of us are familiar with the concept that if you simply look at blood pressure as an index of cardiovascular stress, we know that over the course of the nighttime, and in particular linked to sleep, there is the pattern of blood pressure dipping over the course of the night, which is a good thing that occurs with a surge in blood pressure in the morning with a morning awakening. The dipping behavior of the blood pressure is actually a relatively normal phenomenon and has been associated with improved cardiovascular morbidity and mortality in multiple epidemiologic cohorts. This is very important because the source of non-dipping behavior becomes really critical as we look to ways to mitigate long-term cardiovascular stress and cardiovascular risk profiles over time. And so in that respect, what I'd like to simply highlight is that the non-dippers are people who, over the course of the night, when you look at their blood pressures, they go down relative to wakeful periods, but not nearly so much as they do in the so-called dippers. These are the people who are really uniquely positioned at risk for cardiovascular morbidity and mortality over time. And so it's really this source of cardiovascular stress that is intimately linked to sleep, both sleep duration and sleep apnea, that we really want to be sure that we address by diagnosing sleep apnea with heightened awareness in those who already have underlying cardiovascular disease. And I would really highlight the fact that the non-dipper is a non-dipper for one of two reasons: either short sleep duration, but most importantly, it's these surges in adrenergic activity that drive the blood pressure up repeatedly, hundreds of times over the course of the night, that are associated with sleep apnea and apneic activity. And it's as a result of intermittent hypoxemia and arousals, recurrent arousals from sleep, that lead to these adrenergic surges and surges in blood pressure and cardiovascular stress. This is a unique opportunity for the sleep community to have a measurable impact on long-term cardiovascular risk and cardiovascular morbidity and mortality, because it is the one area that is really not generally addressed by the normal or usual medical pharmacopoeia that is used to deploy, that is often deployed for treatment of various types of cardiovascular conditions, whether arrhythmias or heart failure or coronary artery disease. So this is a unique contribution that we can make to reducing overall cardiovascular stress. Let's turn now for a moment to look at the portable sleep apnea testing platforms. And there's not sufficient time to really cover all of them, but really just to say that the American Academy of Sleep Medicine allows for two basic types of sleep apnea testing platforms. Those that are airflow or pressure-based, nasal pressure or nasal airflow-based, with a complement of physiologic signals that look at respiratory effort and oxygen saturation. Or, as an alternative, peripheral arterial tonography along with pulse oximetry and actigraphy have been allowed as potentially comparable to the traditional airflow-based, tidal airflow-based testing platforms. Now, the American Academy of Sleep Medicine reserves these portable or home testing platforms for patients who you feel to be uncomplicated patients with a suspicion of moderate to severe obstructive sleep apnea. But I must tell you in all honesty that these platforms, home testing devices, are being used increasingly in the field for cardiovascular patient cohorts and patients who are at unique cardiovascular risk as either primary or secondary cardiovascular risk management strategies. Let's look at the flow-based testing platforms. These invariably encompass some sort of nasal pressure or airflow signal, a cannula that gives us a tidal airflow signal, a respiratory effort sensor of some type or another, and oximetry. And from the flow, we derive an amplitude and shape of the flow waveform that gives us an idea as to when patients are having apneas or hypopneas. And it's based on these flow shape parameters that we can also figure out whether patients are having obstructive or central apneic episodes. We complement this information with dips in oxygenation, which are characteristic of sleep disordered breathing profiles, and from the combination of flow amplitude and shape and oximetry, we derive or count the number of apneas and hypopneas. And I'll mention that from these flow-based testing platforms, we count the number of apneas and hypopneas and divide by the total recording time to give us an index of apneic activity, the so-called respiratory event index, the number of events per unit recording time. In contrast, what we see here is an alternative approach where we're looking in essence for the fingerprints of sleep disordered breathing episodes. And we do that by detecting the arousals that terminate these episodes. Now, these arousals are characterized by an attenuation of the pulse arterial tonometry signal. This drop in pulse amplitude in the finger reflects digital vasoconstriction that occurs when there is a surge of sympathetic activity, or adrenergic surge that accompanies the termination of apneic episodes. And when that digital attenuation, when the vasoconstriction occurs in the fingertip, the pulse also increases, heart rate increases, combined with that vasoconstriction to give us what I will term the reciprocal pattern. And this is a reflection of arousals that occur at the end of these apneic episodes. Now, these arousals are given greater specificity by requiring that the arousals per se are related, temporally related to some perturbation in respiration that can take the form of a drop in oxygen saturation, a change in snoring intensity, or a change in respiratory movement. All of these are indications that there's a perturbation in respiration for which that arousal represents the fingerprint from apnea or hypopnea termination. The other feature of this particular testing platform is that the PAT signal is used to derive states of sleep or wakefulness. And so after counting up the apneic episodes, these devices can divide not by recording time, but by total sleep time to generate a somewhat more accurate estimate of the overall exposure to apneic activity over the course of the night, namely the apnea-hypopnea index. Both testing platforms give us, because by virtue of the fact that they look at oximetry, nocturnal oximetry profiles, they give us an indication of the hypoxic burden that patients are exposed to over the course of the night. And this slide that comes from the group at Harvard demonstrates that the hypoxic burden, which is represented by the area under the oxygenation curve over the course of the night, is strongly linked to increasing mortality in large epidemiologic cohorts. Shown here is mortality over a decade or more period of time, with increasing levels of hypoxic burden on these home testing platforms, for example, being linked to increased exposure to cardiovascular morbidity and mortality and to all-cause mortality. So all of these home testing platforms give us this index of hypoxic exposure. A few operational issues will really govern your choice of how to deploy these devices in your particular setting. And I would say, frankly, suffice it to say that all home testing platforms can be used to wring out the important information, and that is namely the presence, the severity, and the type of sleep apnea. And all of them, as you learn more and more about the physiologic input that you get from these devices, you can wring out very comparable levels of information with slight differences. And so I would capitalize on what you're now doing in the home testing arena for a sleep center and think about the logistics of how you would deploy that in other settings to make it more convenient or as convenient for a cardiovascular patient as it is for your patient to get an EKG, an echocardiogram, or a chest X-ray. And I would say that there are a number of different operational issues to consider. The accuracy of the diagnosis, namely, can you determine the presence, severity, and type of sleep apnea? We've spoken or touched on some of those issues, including differences between total recording and total sleep time that may alter your overall estimate of apnea-hypopnea index over the course of the night. But there are operational issues. The simplicity to deploy the instrument, particularly to deploy them at point of care on your inpatient cardiology services or your outpatient cardiology or primary care offices. You might also want to consider the failure rate in the home setting or on the hospital ward, where there's a lot of external environmental noise that may interfere with your ability to successfully get a good quality recording. And then finally, the ease of downloading and scoring these recordings makes a lot of operational difference because it may put various levels of stress or strain on your own sleep center's staffing model. And so the ease of downloading automatically, presumably to a cloud-based repository, and then generating scores automatically or semi-automatically with computer-assisted scoring makes a lot of sense as you consider the home testing platform for each specific clinical setting. And then finally, in the age of COVID, the fact that we need to, as sleep centers that have been used to bricks and mortar sleep testing inside the confines of our own laboratories, we need to be very, very cognizant of the risk of transmitting contagion, namely COVID, by virtue of contact with the testing technology itself. And so you want to think very carefully about your protocols for decontaminating the non-disposable instruments or using disposable instruments for home testing. I'll stop there and say that it's an interesting landscape and a challenge for sleep physicians to take ourselves out of the box and put ourselves in the shoes of our cardiology colleagues to contemplate the landscape of how easy it is to deploy the diagnostic testing strategies, and then to provide for their patients the consultative backup support that they need to effectively manage this unique source of cardiovascular stress, namely sleep disordered breathing. Thanks so much. I'll turn the controls over.
Well, thanks so much, Alan. We are going to try to reserve a few minutes at the end of the hour to have a bit of a panel discussion, so hold your questions or comments. But now let's go into a discussion of OSA and treatment options for heart failure patients from Dr. Shah.
Great, thank you.
Yeah, Dr. Shah, you should have control of the screen.
Okay, great. So yeah, as was discussed, I'm going to be speaking briefly about OSA and specifically treatment options for heart failure patients. And because it's, as you probably are aware, central sleep apnea is more heavily focused in terms of the studies and the investigations we've done. The data on OSA and treatment options for heart failure patients isn't a lot, but I think it's important to review that. So we will hopefully be done within the next 10 minutes. So just to start off with, what is obstructive sleep apnea? I think everybody probably is aware, but I just like to start off with basics. And essentially, it's where the upper airway collapses due to a lack of neural input to the upper airway muscles and the inspiratory pump muscles, either completely or partially, resulting in pauses in breathing in the presence of thoracoabdominal effort, as noted here. And what happens typically is that there is an associated desaturation, and arousal from sleep is indicated here, and this cycle essentially continues throughout the night. And the gold standard treatment, or the primary treatment that we currently have, is continuous positive airway pressure. And when we put an individual that has obstructive sleep apnea on CPAP, we see these nice sinusoidal waves, oxygen saturation is stabilized, and there's really no arousal associated with the respiratory events that we saw before the treatment. So how do we define, or what's the diagnostic criteria for OSA? I think we all know what they are, but I thought it would be important to just quickly review what the American Academy of Sleep Medicine uses to diagnose obstructive sleep apnea. I think in either in-lab or a home sleep study, if you have an event index or an apnea-hypopnea index of 15 or more, that essentially meets the diagnostic criteria for obstructive sleep apnea. However, if you have a milder version with 5 or more predominantly obstructive respiratory events, they do require some symptoms, particularly of note are insomnia symptoms, which we often don't think of, and also concomitant comorbidities such as mood disorder and cognitive dysfunction, in addition to the cardiovascular conditions that we often think of in terms of meeting this diagnostic criteria. So as was already alluded, obstructive sleep apnea, like central sleep apnea, is very prevalent in heart failure, and this is a really good summary figure for that. In blue, you see the overall prevalence of all sleep apnea events, and in red is the prevalence of obstructive sleep apnea, and in gray is the prevalence of central sleep apnea. And these are different stages of heart failure, or different types of heart failure. So of particular interest is heart failure with reduced ejection fraction. You see that sleep apnea is quite common, and obstructive sleep apnea is also common at 20% prevalence, in addition to having a prevalence of central sleep apnea of 33%. But across the board, obstructive sleep apnea is really present in patients with heart failure. And so how does obstructive sleep apnea affect the heart and the right ventricle and the left ventricle, and then potentially contribute to the development and progression of heart failure? And what you see here is an upper airway that's open and the chest cavity with the organs, and here's an upper airway that's occluded. And one of the things that happens as a result of an occluded airway is that there's this generation of these really large, exaggerated negative intrathoracic pressures, which leads to increased venous return in the right ventricle, concomitant with hypoxemic pulmonary artery vasoconstriction, which results in right ventricular distension and leftward displacement of the interventricular septum, resulting in impaired left ventricular filling, decreased left ventricular preload, and decreased stroke volume. And all of this is really exaggerated in individuals with a decreased cardiac output, such as in individuals with heart failure. So this is a mechanical load aspect of obstructive sleep apnea. But then there is also autonomic dysregulation, and specifically in the interest of time, obstructive sleep apnea contributes to increased sympathetic nerve activation, and we know that that is associated with increased mortality in heart failure patients. And finally, obstructive sleep apnea, through its intermediary mechanisms of sympathetic activation we talked about, but also through endothelial dysfunction, hypercoagulability, inflammation, oxidative stress, and metabolic dysregulation, promotes coronary atherosclerosis, which is the commonest cause of heart failure and can be another means by which OSA contributes to the development and progression of heart failure. So we know now that obstructive sleep apnea is common. We know sort of how it may contribute to it, or at least we've reviewed some evidence. And we also can then now talk about how what the epidemiological data suggests in terms of it being a risk factor for heart failure. And this slide is a study from the Sleep Heart Health Study from Dan Gottlieb and colleagues, basically demonstrating that in both men and women, in individuals with severe sleep apnea, shown here, there is an increased risk of mortality, especially with more severe sleep apnea, and more in men than in women. And then similarly, if you already have obstructive sleep apnea, so the last slide was showing you in individuals for incident heart failure. This slide shows you in individuals that have heart failure, what is the contribution of OSA in terms of mortality. And here you can see in red, mild to no sleep apnea. And then at the bottom, you see that individuals that have untreated obstructive sleep apnea really do have poor survival. So it does have prognostic implications in individuals with heart failure and reduced ejection fraction. Similarly, individuals with acute heart failure and left ventricular EF of less than 45%, this slide again shows a poor survival in individuals in blue that have obstructive sleep apnea compared to those that have mild to none sleep apnea, with a hazard ratio of mortality independently from obstructive sleep apnea of 1.53. And interestingly, in this study, they were also able to look at what is the impact of treatment, and it's not a randomized trial, but in the observational setting, after discharged individuals that were on treatment compared to individuals that were not on treatment clearly had a much poor survival in both the OSA and the central sleep apnea groups. So it appears that treatment post-discharge for acute heart failure may also improve survival based on this non-randomized trials data. So we've now talked about sleep apnea being common. We've talked about how it may contribute to heart failure, and then we talked a little bit about prognostic implications. So just touching briefly on the effects of the actual heart failure therapy before we go on to the obstructive sleep apnea treatment, there have been some studies that have tried to look at really what is the impact of drugs that are commonly used in heart failure patients on the OSA prevalence, but unfortunately most of the data suggests that there's very little effect on the overall prevalence of OSA in stable heart failure patients. Similarly, fluid retention from heart failure may contribute to the pathogenesis of OSA, specifically with rostral fluid shift during sleep. And so the effects of furosemide and spironolactone in diastolic heart failure has been studied in OSA patients. And this too, although resulted in pharyngeal caliber improvement measurements, the overall AHI really, as you can see here, remained in the severe category. And again, this is very limited data. So atrial overdrive pacing, cardiac resynchronization therapy, and exercise programs have also been looked at, and they do appear to reduce AHI, but I don't think we have enough data, especially in the OSA population, to really draw any broad conclusions about the impact on OSA prevalence. So if you look at then the clinical trials that have actually looked at what happens when you treat individuals with OSA and heart failure with CPAP, and these are randomized controlled trials, 4 of them shown here, small sample sizes, so really hard to draw big conclusions, but it does appear that CPAP, fixed pressure CPAP does appear to increase left ventricular ejection fraction, especially in individuals with more severe sleep apnea, as shown here, and a more severe heart failure, as measured by a more reduced ejection fraction compared to other studies. And then CPAP also appears to improve Epworth scores and quality of life in patients with heart failure and OSA, specifically for those that were sleepy to begin with, as shown here, as opposed to individuals that really weren't sleepy to begin with. So these are cardiac function, left ventricular ejection fraction, and things of that nature. What about actual morbidity and mortality? What happens when you treat individuals with OSA who have OSA with CPAP? And again, we don't have too much data on this, but what we do have does suggest a trend for reduced mortality in the treated group and lower death and hospitalization risk in these 2 studies that I show here. And although these results are promising, these results are really not conclusive because they were not randomized in nature, and as you can see, their sample size is rather small. So we all are aware of the SAVE trial, and again, in the interest of time, I'm not going to go into it, but this is the largest randomized controlled trial we have in obstructive sleep apnea and cardiovascular disease outcomes, and this study specifically was designed to look at the impact of CPAP on secondary cardiovascular disease prevention. And although it did not show a demonstrable effect of CPAP on the composite outcome of cardiovascular disease events, they did look at heart failure related hospitalizations specifically, and you can see here that heart failure hospitalizations were also not different in the CPAP group versus the control group. And again, this is not a heart failure population, but this is the best data we have in terms of a large randomized controlled trial that has looked at cardiovascular events and how they are affected by CPAP therapy. So what do I do with patients myself in terms of heart failure, in the heart failure population, specifically talking about OSA? Of course, we want to target the behavioral aspects. And so weight loss and exercise, sleep position, specifically avoiding supine position, alcohol avoidance, and medications such as benzodiazepines, especially that worsen obstructive sleep apnea, should really be avoided. In terms of PAP therapy, we do have multiple different options. We have continuous positive airway pressure therapy. We have auto CPAP, which is auto titrating continuous positive airway pressure. There's bi-level, and then there's ASV, which is the adaptive servo-ventilator. And, you know, for the most part, for patients who have underlying heart failure, I'm inclined to use fixed CPAP, not auto-titrating CPAP, because of the concern of having secondary central sleep apnea either present or develop as their heart disease progresses or gets better. So that's one option in terms of specifically targeting this for the heart failure patient population. Bi-level also is a recommended treatment after CPAP, but again, I usually avoid using it for the same reasons, that it can potentially worsen central sleep apnea that is usually present in individuals with heart failure, as the slide that I showed you in the beginning of the talk. And ASV, I reserve ASV for patients who have central sleep apnea and obstructive sleep apnea, but primarily in the opioid-induced category, and especially because of the SERVE-HF trial, it is contraindicated in the treatment of central sleep apnea and heart failure, which I'm sure Dr. Goldberg will go into more next. We do also have other non-PAP treatment options for OSA. There is the surgical options, including correcting upper airway obstructive lesions. Tonsillectomy and adenoidectomy is really recommended more for children. And then we have an FDA-approved treatment for obstructive sleep apnea in individuals that have failed CPAP, and it's called Inspire, which is a hypoglossal nerve stimulator. How this treatment specifically would do in an individual that has predominantly obstructive sleep apnea and heart failure that's stable, I'm not aware of data specifically on that, but it would be interesting to look at. We also have pharmacological treatment options, a combination of norepinephrine reuptake inhibitor and antimuscarinic agent reduced AHI by more than 50% one-night usage, and this was published in the Blue Journal by Andrew Wellman's group. And again, it's really not ready for mainstream, but it's promising and can be potentially used in the future as an investigational agent in heart failure patients, specifically with OSA. And then, of course, we have modafinil for persistent sleepiness in patients who are using their conventional OSA therapy and remain sleepy despite being compliant. So in summary, OSA is prevalent in patients with heart failure. It has adverse cardiovascular effects, as I showed you, and we've already discussed through the other panelists, and is associated with reduced survival in heart failure patients. And small randomized controlled trials are showing that treatment of OSA does improve cardiovascular and autonomic function. And in patients who are sleepy, it does reduce sleepiness, but really we have limited data from randomized controlled trials on CPAP specifically, and how that impacts morbidity and mortality in heart failure patients. I think future research on alternatives to CPAP should really be considered, and we need to acknowledge that OSA coexists with central sleep apnea and heart failure patients, and we really need to think about treatments that are directed at both, and ultimately in order to understand the impact on mortality in heart failure patients. So with that, I'm going to stop, and I'm going to pass it on to Jody.
Fantastic. Thank you so much. Let's keep rolling right into Dr. Goldberg's presentation on CSA.
So thank you very much. So I am going to pick up the ball to talk a little bit about central sleep apnea and heart failure. So first, just to review, cardiovascular conditions and sleep, one of the reasons that a lot of us have become interested in this area is that many of our patients do complain of fatigue that can be multifactorial, and we worry that some of these things, some of these symptoms actually limit some of the mortality benefiting therapies, including beta blockers, that can really benefit patients with cardiovascular disease. And then we also know that a lot of the outcomes that we're interested in, arrhythmias, myocardial infarction, worsening heart failure, are driven through the adrenergic system, which is clearly upregulated by sleep apnea. So I'm going to be focusing on the pathophysiology of central sleep apnea. And you saw already in obstructive apnea that there's effort and then there is a closed airway. But in central apnea, There's hyperpnea, meaning that the patients are hyperventilating, and then episodes of apnea, but the airway is open. So this results from an intermittent loss of the neural drive to breathe. And the prevalence is high in patients with heart failure, and there are very few therapeutic options. And like obstructive sleep apnea, we see that untreated CSA leads to hypoxia and fatigue, increased blood pressure, arrhythmias, and increased risk for heart failure, hospitalizations, readmissions, and mortality. Now, we know that the majority of patients with central sleep apnea have underlying cardiovascular disease, with more than half having heart failure, but a large percentage also having atrial fibrillation and heart failure combined, or atrial fibrillation alone, and then smaller numbers having stroke or being idiopathic. And central sleep apnea has really significant impacts, meaning that the apnea and hypopneas that occur lead to hypoxia and arousals, ischemia and inflammation, and activation of the sympathetic nervous system, and ultimately lead to these outcomes, which is high rates of heart failure and atrial fibrillation, high levels of heart failure readmission, and a very high level of mortality in this group. And unfortunately, there are very few treatment options for this population, and that's been a real challenge. Now, we know that the presence of central sleep apnea significantly increases mortality in heart failure patients, and there's a dose-related effect, meaning the worse the AHI, the higher the mortality in our patient population. And we know that as this it goes from not severe to severe, there's also a significant increase in mortality over time. We also know that central sleep apnea increases heart failure readmissions, and so the more central sleep apnea you have, the more likely you're to be readmitted to the hospital, which is one of the quality metrics that a lot of our heart failure programs in hospitals are being judged upon. Now, we know that central sleep apnea is underdiagnosed in cardiac patients. We know the typical patient is male, has a lower BMI, a lower left ventricular ejection fraction, a more dilated left ventricle, and then there are several other clinical identifiers. So having heart failure, atrial fibrillation, or stroke, frequent heart failure hospitalizations, arrhythmias, including ICD discharges, witnessed apneas, frequent waking up, nocturia, and then poor exercise tolerance and fatigue. And if you think about it, nearly every patient that presents to our heart failure clinic has one or more of these symptoms. And so screening these patients becomes very important. Yikes. Okay. So what about the treatment of central sleep apnea? Well, we know that there are several therapies that you just heard about for OSA treatment, but for central sleep apnea treatment, there's actually very few therapies that have been shown to be beneficial, mostly because clinical trials have really not shown benefit. And you heard hinted that the adaptive servo-ventilation, which had been studied in a small pilot trial in the US and a much larger trial in Europe, SERVE-HF, showed that in patients with low ejection fractions, that there was excess mortality and a real risk to using ASV in that population. And then other medical therapies like acetazolamide and theophylline have significant cardiovascular risk at high dose and also have not been approved by the FDA to treat central sleep apnea. But phrenic nerve stimulation, which I'm going to focus on in just a minute, is the one therapy that for patients with low ejection fraction is approved. And then these are just some of the data that talked a little bit about the black box warning that we have, unfortunately, for ASV therapy in patients that are symptomatic and with ejection fractions less than 45%, that these patients actually are not to be treated with adaptive servo-ventilation. So phrenic nerve stimulation is a new approach for the treatment of central sleep apnea. And we're talking about a fully implanted treatment, a pacemaker-like device that stimulates the phrenic nerve. And it creates a more physiologic pattern of breathing, meaning that we're stimulating the phrenic nerve in the diaphragm, creating negative pressure ventilation. And this leads to a more natural breathing pattern and perhaps avoids some of the risk of positive pressure and some of the pressure that we see in the chest that can lead to some of the negative side effects that we've seen. Now, this system activates automatically at night, so it removes the need for patient interaction, meaning that they don't have to put on a mask or do something actively, but rather, like almost all of our implantable cardiac devices, activates automatically. The system is implanted with two leads. One is a sensing lead, and the other is a stimulation lead that actually sits inside the blood vessel and then stimulates across the wall of the blood vessel into the phrenic nerve. So there's no direct contact with the phrenic nerve, and therefore no fibrosis or loss of capture occurs over time. And one side is stimulated, and that's adequate to create enough respiratory motion to restore normal ventilation. And this can be placed on the left side or the right side. And it's very similar to other pacemaker devices, ICDs and biventricular pacemakers, that our electrophysiology colleagues implant regularly. And this is what the system looks like on X-ray once it's implanted. So this is an example of what the patient looks like with the therapy on. So this is regular airflow, normal movement of the abdomen and thorax, and a relatively normal oxygen saturation. And then when the therapy is turned off, you can see the restoration of Cheyne-Stokes respiration and then apneic episodes, as well as desaturation and loss of thoracic and abdominal movement. So this is the clinical trial. We call it the pivotal trial of the remedē system. It was a prospective, multi-center, randomized controlled trial, and patients had to have moderate to severe central sleep apnea scored by a blinded core laboratory, AHI greater than or equal to 20%, and a central apnea index of at least 50% of all apneas with at least 30% central events, and then an obstructive apnea index that was relatively low. The primary effectiveness endpoint was a sleep endpoint, comparison of the proportion of subjects that had a greater than or equal to 50% reduction in AHI between treatment and control as intention to treat. Our safety endpoint was freedom from serious adverse events, and then a series of hierarchical secondary endpoints, each of which had to be achieved in order for us to be able to move on to the next endpoint. So first, central apnea index, if we achieve that one, then we could look at apnea-hypopnea index, etc. This is how the therapy was applied. There were 151 patients, all of whom were implanted with the device. 73 of them were randomized to have treatment on at 1 month and then be followed out to 12 months. 78 of them were randomized to have the therapy off for the first 6 months and acted as controls. And then at 6 months, they all crossed over, and we had an additional 6 months of the former control group now being treated. And then we continued to follow them out every 3 months. And we have data out now several years from this clinical trial to show long-term efficacy and safety. This is the demographics, a typical central sleep apnea central sleep apnea population. About 80 to 90% of them were men. With not very high body mass indexes compared to the OSA. Remember that this trial enrolled all patients, so although many had low ejection fractions, many did not. And so you can see that the ejection fraction was about 40%. Atrial fibrillation was relatively common, about 40 to 45%. And then they met the inclusion criteria in terms of apnea, hypopnea index, etc. And this is the slide that actually shows the efficacy, that there was a statistically significant reduction in the primary endpoint, meaning a greater than 50% reduction in AHI. And then in each of our secondary endpoints, statistical significance was achieved, and therefore we were able to analyze both the specific sleep endpoints as well as a quality of life assessment in our secondary endpoints, all of which were statistically significant. If we look at the patients, how many of them had AHI reductions, here's the whole population at 6 months and then at 12 months, and you see the vast majority of patients, 88%, had a decreased in the number of apnea-hypopnea index, and then 91% at 12 months. And our primary safety endpoint was also met, meaning 97% of the time the implant was successful, and there were no deaths related to the procedure, the system, or therapy. And this was very reassuring as data from SERVE-HF and other trials was being released around the time that we were doing this trial. We did also see that patients noted a significant improvement in quality of life, and 96% of the patients were willing to undergo an invasive procedure, meaning the placement of the device, in order because of the benefit that they received. So 96% would elect to have the procedure again. If we look at our control patients, a very similar pattern, meaning that once the device was turned on, they also had a similar effect, and they too had a significant improvement in their global assessment or their quality of life, and were also willing to undergo the procedure again. When we look out to 36 months long-term follow-up data, we see that the sleep metrics were maintained exactly as we would have anticipated out over time with no decrement as time went on. And then if we focus specifically on the heart failure patients, there was a similar benefit in both sleep and in quality of life as we saw in the trial overall. And this again was very reassuring that in the subgroup of patients in this trial that had heart failure with reduced ejection fraction, that they too saw a significant benefit in both, again, the sleep parameters and quality of life. And then if we look at some exploratory analyses, we saw a small increase in left ventricular ejection fraction that was statistically significant, showing at least no decrement and potentially a benefit. And we also saw a reduction in time to first heart failure hospitalization, and then no difference in cardiovascular mortality. Again, a very important endpoint to look at given the data that we had from SERVE-HF. So in conclusion, central sleep apnea contributes to a harmful progressive cycle of hypoxia, arousal, and sympathetic activation. There have been very few treatments for central sleep apnea and limited randomized data to date. But now we have an FDA-approved therapy, a phrenic nerve stimulator, that offers a new therapeutic option for the treatment of patients with central sleep apnea, particularly the heart failure group, the heart failure with reduced ejection fraction, which is not able to be treated with adaptive servo-ventilation. So thank you very much.
Okay, well, thank you, Lee, and thanks again to all of our speakers. We do have a few minutes. Participants are welcome to stay on the line even a few minutes past 6:30 Eastern. We'd like to address your questions. You know, I would like to start by asking the panel in the COVID-19 era, in order to enhance patient safety and minimize exposure. Can you envision a pathway in which patients can have, perhaps virtually, all but maybe in the case of an implantable, transvenous phrenic nerve stimulator, have all of their evaluation done remotely at home, telehealth visits, remote testing, and so on and so forth? What do you think, Neomi?
Yeah, I mean, I think that it's a reasonable thing to be considering at the moment. I know for sure that our institution is really trying to ramp up home sleep testing, specifically testing that offers disposable devices, just because of the concern for COVID. Obviously operational issues, but financial issues also sort of dictate how we can continue to do that and stay, within our budget. So that's really the main concern that we are at the time facing. But disposable HSTs is really the way to go in the post-COVID era. Not sure if I answered your question, but I was trying to answer a question on the Q&A, so I was a little distracted.
Yeah, no. I think that's very useful. Alan, any additional comment about that?
Yeah, I think there are a couple of considerations here. Number one is we tend to be in the sleep field a bit too reductionist in quantifying the exposure, nocturnal exposure, just solely on the basis of AHI. But I think we really have to serve up really a panoply of physiologic markers of physiologic distress at night, many of which have cardiovascular implications. I mentioned the hypoxic burden. I mentioned the fact that the oxygen desaturation index is really a useful complement to just the apnea-hypopnea index. And I think as we get closer and closer to understanding the impact of sleep disorder breathing on sleep quality metrics, that also really reflects very heavily. Neomi mentioned the fact that epidemiologic cohorts and treatment trials seem to suggest that it's really the sleepy patient with sleep disorder breathing who is uniquely at risk for cardiovascular disease. And so I would emphasize really those metrics from our home testing platforms that allow us to draw conclusions not just about sleep apnea indices, but also about sleep overall. Because as sleep deteriorates, we expect not only daytime function to become impaired, but we also expect worsening long-term cardiovascular outcomes. And this is really what is so important from what Lee was just mentioning, that the response to the remedy system demonstrates not just improvements in AHI, but improvements in sleep quality and daytime quality of life. That we should really, as a sleep community, become much broader in our ability to encompass the outcomes that really matter for long-term cardiovascular health. And so I would really push the testing platforms to yield as much information as possible to not just define apnea-hypopnea index, but hypoxic burden, metrics of sleep distress or sleep quality indices, and then look at our patients from the point of view of daytime function and quality of life.
Okay, well, thank you for that. There are a number of questions that have come in from the audience, so let's work through a few of these. First of all, and maybe we'll start with Lee on this one. You know, what do you see as the barriers to screening of patients for sleep disordered breathing?
Yeah, so, there's a couple. One is having a great relationship with your sleep lab. I think you, Bill, and I have a wonderful relationship where there's a connection between specifically our heart failure program and our sleep lab. So having a very responsive sleep lab is one way. But then we also, on the cardiology side, we have the patients. And so we have to be very systematic about our screening and approach, and then engaging our patients to convince them to actually go and get the testing. And so it really becomes almost like a cultural change in the clinic that we're screening this as another important risk factor. Just like we would think about any other therapy that we're applying, any drug therapy, we're also thinking about sleep. So we screen patients when they're new to the practice. We periodically rescreen if they're treated with a device. We actually include it as a medication on the med list so that we reconcile at every visit and identify challenges. And we've really changed the culture. I think for patients, CPAP has a bad rap, and so sometimes patients would rather not be screened in order to avoid the possibility of needing CPAP because they've heard things or whatever. And I think reassuring them in terms of talking about quality of life improvements, reduction in mortality, reductions in progression of heart failure, and really knowing that data can really help convince patients and their families that it's worth being screened, and then figuring out the therapeutic options afterwards. It doesn't always have to be CPAP, so we certainly can negotiate, but knowing what they have, I think, can be very helpful.
Yeah, any comment from Alan or Neomi?
Yeah, I agree that what works for patients tends to work for docs. And the more that we as a sleep community can extend our reach by providing really convenient testing options for patients. Ideally, patients actually don't have to go to the sleep center, but can really pick up the testing device in their cardiology offices. And then let the device be transmitted electronically through the cloud or otherwise, so that, or through drop shipment to the patient's home and then back again to the sleep lab, so that there's really a seamless process. As easy as just getting a blood draw or an EKG from the cardiology clinic.
Yeah, I agree with what Alan just said. I think making the process seamless is really important. And I think one of the things that COVID has made us do is really not only use telehealth more in sleep medicine, which probably should have been done more to begin with, but also really providing home sleep testing that doesn't require the patient to come pick up the device and drop it back. And I think, we just launched a clinical trial with some funding from Itamar, and they were generous enough to donate some devices. And I have to tell you that the process was just so much easier, even in a research setting. So I can imagine from a clinical perspective. But yeah, I think making it seamless is really the key in order to ensure that patients want to come and get tested.
Yeah, fantastic. Very, very important message. Let me address one question because I think it's a simple answer. And the question is, can you use phrenic nerve stimulation in the pediatric population? The answer is no. It hasn't been studied or approved in that population, and really the device and in particular the leads are sort of sized for adults. So I guess in young adults, but not strictly in the pediatric population. And here's an interesting question. I have no experience with it. Be interesting to know if any of you do. But the question is, can you use a dental device after the CSA is successfully treated with the remedē system? So, you've treated the CSA. There's still some residual OSA that you want to treat. Any reason why a dental device, couldn't work in that setting?
Yeah, I think it's absolutely a good option, and it's often used. It's not something that we use as a primary treatment of OSA, regardless of whether or not there is underlying CSA, but definitely can be done, especially if the CSA is treated through some other alternate methods that we've discussed.
Okay, here's one. We'll start with Lee. But again, I'd love everyone to offer an opinion on. The question is, what would be the sleep apnea testing criteria for heart failure patients in a heart failure clinic? And how would you suggest to implement that screening process in the clinic?
So we use a short sleep screening questionnaire that we've used now for many years. We've actually added a couple things to it more recently, but we ask patients about daytime somnolence and falling asleep. We ask about witnessed apneas, and we ask them now more recently, we've been asking about nocturia. And that's because we used to chalk all the nocturia up to the diuretics that we give in heart failure clinic, and most patients will tell us that story. But we found a strong association between patients having nocturia, say 5, 6, 7 times a night, having their sleep apnea treated, and suddenly they're getting up once a night, and we haven't changed their diuretics or done anything else except for treating the sleep apnea. So we kind of have a structured way of asking questions, especially in patients new to the program. We also then have a very simplified process in our clinic once we identify someone that we want to screen, which is a lot of our patients, where we have an order in our EHR, and it's a simple click, and that sends the order over to the sleep center. It has some conditional orders built in so that they can get either a home study or an in-lab study kind of based on the assessment. It pulls some clinical data into the requisition. And then the sleep center actually has a coordinator that's assigned to the heart failure and to our EP programs that then reaches out to the patient and takes care of getting them the sleep study and then doing the follow-up. And that has made it very seamless for us on the cardiology side, meaning that we do the screening, we identify, and then we push a button, and then they take care of it from there. And then results and communication comes back through our EHR. And so that's been a very efficient system for us. And once we had that set up, the number of patients that we were screening went up dramatically.
Yeah, fantastic. And we do, as you know, we do something very, very similar. Although I want to hear from Alan and from Neomi as well. But I'm also going to offer another way of looking at this in a moment. But go ahead. Let's hear from the sleep specialist about what you think is the most efficient way to screen a heart failure clinic population.
Alan here. The conundrum for me is the cardiovascular patient is oftentimes fatigued, and it's easy to chalk up the fatigue to the underlying cardiovascular condition, particularly in heart failure patients. But I think to take the next step, whether it's through a simple questionnaire instrument or in the end of the day, we're interested in really just probing a couple of different domains, symptom domains, to raise the flag on sleep disorder breathing in this population, particularly if they're fatigued. I'm asking about breathing problems or disturbances in breathing overnight. In the heart failure patients, it can masquerade as paroxysmal nocturnal dyspnea, but it is also just as likely to be central apneic episodes that awaken people with a gasp, a start, or a choke. And that, in addition to breathing disturbances at night, I'm always asking people whether their sleep is just restorative or refreshing or restful. And if any of these basic, simple questions come out positive, then I'm ready to, and my threshold to testing is very, very low.
Yeah, and we do something similar. I mean, we work very closely with the heart failure team, but also the interventional cardiologists and the EP doctors. And so we have a cardiology specific referral path that's been set up to expedite that. In terms of identifying cases, I think we've all discussed how prevalent sleep apnea is, and especially in the coronary artery disease patients, it's as high as 80%. So I don't really personally use a lot of questionnaires because it's very hard to figure out who does and doesn't. But I think to Alan's point, if the patient is symptomatic, that's really the biggest reason to consider testing. And those are the patients we highly encourage, and we try to get them in as soon as possible, either for in-lab studies when needed or expedite the home testing and make it easy for them and seamless.
Yeah. And the other thing to consider perhaps really is the patient with atrial fibrillation is really uniquely predisposed to both central and obstructive sleep apnea. And so that's a special patient population where the evidence that's emerging indicates that if you manage the sleep apnea proactively, you'll get better AFib outcomes as well. So I would highlight that particular cardiovascular population.
Yeah, I think that's a really important point, Alan, really important group to go after aggressively. And then, the provocative answer that I would have to this question, for the group, but I think you've actually all kind of said the same thing, is that, given the fact that the symptoms of heart failure and sleep apnea are overlapping, you could make a case for screening virtually all symptomatic heart failure patients. Certainly patients who have been treated with guideline-directed drug and device therapies and remain symptomatic. Until you look, and because those questions may not be fully sensitive until you really look for it, you don't know who has it. And if we're looking at, 70, 75, 80% of the heart failure population, for example, having some form of sleep disordered breathing, you can make an argument to screen everybody. Certainly, we screen everybody for ischemic heart disease, all heart failure patients for ischemic heart disease, and its prevalence is about 65%. So, to be provocative, I would say we should be screening, all symptomatic heart failure patients if you have the capacity to do so.
So, Bill, my close colleague Lou Pham just wrote in, is one sleep study sufficient to diagnose?
Okay, tell us the answer.
Well, I was going to ask Neomi. My answer is if it's positive, it probably is. But the real key to the question is make sure it's sleep. In other words, if the patient really has insomnia, then and that's the major presenting issue, then the patient may not be sleeping adequately to really get an accurate assessment. Obviously, if it's positive for sleep disorder breathing, then I would go ahead and rest my case on the basis of that one sleep study. But if there's any indication that the patient has insomnia, then I would either emphasize a testing platform that interrogates for sleep-wake patterns, or make sure that the patient get tested again if negative, if your clinical suspicion still remains. Naomi, what do you think?
Yeah, I think it's obviously a concern because central sleep apnea sort of can evolve and worsen and improve as heart failure management is addressed. Obstructive sleep apnea, I think, is a little bit more straightforward. Even that, I think, with worsening of heart failure, OSA can also potentially worsen and improve. So what I do is I typically will use the positive test, as you mentioned, Alan, and if there is evidence of obstructive sleep apnea, that's an easy one. If I suspect that they may have central sleep apnea, especially if they're in the high category % prevalence, then I would probably do an in-lab study just to make sure that that's happening. And then if there is no central sleep apnea, we would start with standard treatment. But I observe these folks very carefully and follow sort of residual AHI on their downloads as an indication for it. And if I see that there is persistent residual events, I have a low threshold from referring them back for a repeat study.
Okay, well, it looks like there are no more questions coming into the Q&A queue, and the audience participants are starting to dwindle a bit, although I'm really encouraged to see 54 folks still on the line, so I want to thank you all for hanging in with us 15 minutes beyond the scheduled end of this webinar, but I hope that you have found this useful. I want to thank our three presenters who have done a fabulous job, not only in their presentations, but in helping to answer our questions, and wish you all a great evening. Thank you again.
Great. Thank you so much.
Thank you.
Thank you all.
Thank you.
And I'd like to thank you as well on behalf of Respicardia for this great presentation. I always learn something from each of you, so thanks so much for being on. So thank you all.
Great. Thanks so much. Bye.
Bye-bye.
Pleasure.
Bye-bye.
Bye-bye.